Hey everyone, my name is Eric Norman, and I'm a physical therapist here with Mettle. And shortly I'll be joined by my colleague and friend Christian Jorns, who's also a physical therapist. And today we're going to talk about the hip. We're going to do kind of an interview style podcast, so we're going to go back and forth a little bit with asking each other common questions we might hear in the clinic, and hopefully reveal some good insight to individuals who might be dealing with hip pain at this time, have dealt with it prior, maybe wanting to prevent stuff going forward, or if you're just generally interested about the hip, hopefully you can take some good things away from it. So thanks so much for tuning in today, and hope you enjoy. Hey Christian, how's it going?
Hey, things are really good over here. Just enjoying a great Saturday. How you doing?
Right on. I'm doing well. I'm actually, for people that are watching this, I'm in a hotel room right now. So I'm actually in Rochester at a wedding right now. So I'm in a hotel room kind of waiting for the wedding later this afternoon, and figured let's be efficient with our time and knock out a podcast. So
Yeah, and just be on high alert for whoever gets injuries on the dance floor.
yeah,
There's
that's
always
right.
one. There's at least one.
Yeah, that's right, man. Yeah, that's funny. I actually just had a patient who got injured dancing at a wedding. So no, I'm not
Nice.
joking. She tore her ACL
Oh,
dancing at the wedding.
no. Oh, okay.
Side story. Anyways, oh man, transition from that,
Great. Abandon that one.
right? I had a surprisingly good workout this morning at the hotel gym, not gonna lie. Using a couple of dumbbells and just doing whole body stuff like overhead and like some burpees and stuff like that. Don't underestimate the utility in that stuff. That was a heck of a workout.
Yeah, you lost me at burpee, but I'm glad you had a good time.
What's new with you, man? How's your exercise program been going?
Going okay, still getting back into the groove of things. I forgot if I told you or not, but I tweaked my groin, my left groin,
Oh, okay.
in the bottom of my squat a couple weeks ago. So, like when it first happened, it was kind of alarming. So I stopped, took some weight off the bar, tried again, and it still hurt pretty bad. Tried that again, also still hurt. So I ended up
Jeez.
just stopping for a handful of days. Thankfully, though, it was only sore for a couple days, so I don't really feel like I had like a real injury. I think my groin was just, I don't know, not used to squatting like that in a while.
Yeah.
So today, though, things felt particularly good. So I had a good training day as well.
Nice. Glad to hear it, man. I always love to hear a good squat session. So we're going to get into some of these questions back and forth that I talked about in the intro between Christian and I, and we're going to be talking about the hip today. I'm going to let Christian take it away, asking me the first question.
Yeah. So, Eric, what is the hip?
It's a great one. Fantastic question. Yeah. So what is the hip? The hip it's a joint in the upper leg, right? So it's that what we would call more proximal or closer to that spine. And the hip is actually made up of two parts. So you can think of it as what's called a ball and socket joint. And the ball and socket joint, the ball portion of it is from what's called the head of the femur. Femur is that long bone that spans all the way from the hip down to the knee. And that head is what's called articulates. And articulates just a fancy word for two surfaces of bone interacting with each other. And so that head of the femur articulates with what's called the acetabulum of the hip, and that's the socket portion. And so those two portions of the hip make up the ball and socket. The ball and socket joint allows for what's called a lot of degrees of freedom. All right, so degrees of freedom is just another fancy term we use in physical therapy to talk about different planes of motion that something can move on. Because the hip has a lot of degrees of freedom, we can see it can move in multiple directions. It can rotate, and that's what's called the transverse plane. So if you want to turn your foot inside and out when you're standing, that's called rotation or moving in the transverse plane. It can also move in what's called the sagittal plane, or that's kind of like if you're kicking, right? So kick that leg forward and back. And then lastly, it can move in what's called the frontal plane. So that's sweeping the foot side to side in front of your body. So as you can see, lots of different motions, which set up for lots of potential places to get injured. Anyway, last thing I want to touch on with the hip, because I think it's really interesting, is the hip bears a lot of weight, right? So a lot of weight goes through the hip, and because of that, it needs to be very mechanically stable. So what we also see in the hip, just like the shoulder, is we have what's called a labrum. And labrum is just a piece of connective tissue that helps provide more mechanical stability. And it's really interesting that actually in this case, in the hip, it kind of grips that head of the femur that we talked about into the socket and makes sure that it's, very stable in doing that. And there's actually a little bit of discussion around manual therapy in the hip. I don't know if Christian, you remember, I'm sure you do, back in cadaver lab days when you would pull around that femur a little bit, the head of that femur, and you could feel just how solid it is in that joint because of the joint capsule and the labrum. There's actually some discussion that because of how tight and stable that is, if we're doing manual therapy to it, trying to move that joint a little bit, people argue, are we even really moving it because of just how stable it is with that labrum causing that gripping effect of that head into the acetabulum.
Great introduction to that. I was actually getting a little anxious as you started because I was getting crazy flashbacks of the first week or two of PT school, year one, just learning all about biomechanics and stuff.
Oh yeah.
Yeah.
Absolutely. I know. Yeah, thinking back to cadaver lab and seeing a body for the first time, getting a little woozy.
Mm-hmm.
But anyway, all right. So now it's my turn to ask you a question here. Christian, what are the major muscles in the hip area?
Yeah, so I wanted to break this down just by the sides of your hip. So we have three major sides. We have the front, the side, and the back, also called anterior, lateral, and posterior. The muscles in the front of your hip are called your hip flexors. And the hip flexors are responsible for moving your leg forward for things like walking and running. And you'll see that these muscles typically get developed in people who run really fast, like sprinters, or people that kick a lot, like soccer players or MMA strikers. And those are the same kinds of people where you tend to find injuries in these muscles. The muscles on the side of your hip are called your abductors, and the muscles in the back are generally called your glutes. However, the abductors are actually named gluteal muscles like gluteus, medius, and minimus, so think of them as your glutes too. The abductors are super important for being comfortable in anything involving being on your feet. Weak or poorly coordinated abductors are linked to all sorts of issues, like running-related injuries as a whole, knee pain, foot pain, and bone stress injuries. You should know that the link is not super strong, and it varies for each diagnosis, but it does seem meaningful, at least in my opinion. The glutes often get a bad rap because it seems like literally every healthcare provider, trainer, and social media post is going on about how you should do some kind of glute activation or train your glutes with clamshells, leg lifts, bridges, hip thrusters, or monster walks. And while yes, we definitely do prescribe hip abductor work for people all the time, it's not like they're required for everyone. Personally, I don't think I've done a single working set of clamshells or anything else like it in at least 5 years. And I generally keep my glutes strong enough doing things like squats and deadlifts and their variations. But sometimes I will train things like lunges or pistol squats if I want to target those glutes a bit more.
Absolutely. No, I think you broke down those glutes and their function and importance really well because, like you said, we hear about it all the time, especially on social media. It's almost like become like a clickbait thing now, I think, of just like your glutes are sleeping. Let's wake them up. And people are like, what? My glutes are sleeping. So I think you did a good job breaking that down there. That was nice.
Well, we're not done with the glutes yet. I want to stay on topic. So, Eric, why do I hear so much about strengthening my glutes?
Well, you hear a lot about it because the glutes do have some functional purpose within our body and different things that we do, right? And so one thing that I think is good to discuss is kind of going off what you said is the role of the glutes, right? So you kind of mentioned how there's three different parts or muscles of the glutes, right? You have your big gluteus maximus in the back, in that kind of buttocks region. But what people I feel like sometimes don't realize is that your glutes are also wrapping around on that side, like you mentioned, the lateral part, the glute minimus and the glute medius, and they have different roles depending on which parts of those muscles we're talking about. So glute maximus, that one's big with the hip extension, right? I mean, I think you mentioned squatting, and I think one of the big things that we overlook sometimes is why are glutes important? Well, look at an elderly individual or someone that might have weak glutes, and because I don't want to say that just elderly individuals have weak glutes, but when we look at like a sit to stand, right, that's basically just a squat with a little pause at the transition point or the sticking point, and having really weak glutes, especially as we get older, can really affect how efficient we are with doing that motion. Next, I want to talk about the glute medius and the glute minimus. So those are more on the side, and we discussed how those play a role in hip AB or abduction. One of the big things we need this for is just walking, right? As that, let's say your right leg is off the ground and your left leg is what's called in stance phase. Those left hip abductors are doing a really good job for a lot of individuals, making sure that your pelvis is leveled out. When you see part of that pelvis dip, that's a really common sign that we call a Trendelenburg sign. So those are two functional reasons why we hear a lot about strengthening the hips. Now we can get into even more sports performance aspect, right? Every time, if you're a long distance runner and let's say you run a half marathon, I mean, however many steps you're taking, right? Every step you take, the glute med and the glute min are making sure we're not doing that Trendelenburg sign every single step. And so if we have weakened hip abductors and you want to run a half marathon, you want to run a full marathon, and that over time can, cause an issue. Maybe if you just do a 5 or 10K, you're good. You don't have to worry about it. But if you want to get way up there in mileage, and now that's another reason why we hear about strengthening those glutes. You can even look at it in, sports like football or rugby, right? When you're in the trenches and you're an offensive or defensive lineman or an individual in rugby that's, in that, forgetting the name of that pile. Oh man, I
Scrum.
hope we don't have the scrum. There we go. I was going to say, I hope we don't have people with rugby backgrounds watching this because they're going to tear me apart.
Well, not anymore. They just left.
Yeah, there we go. The scrum, if you want to get some really good push going, you're creating a lot of force through those glute maximus, pushing forward. And then just things like jumping, right? Even landing from a jump, that eccentric or that control down from a jump. These are all reasons why hip strengthening or glute strengthening is really important.
Awesome. Yeah. And that just reminds me of one of the studies we had to review in Journal Club at work. I think it was last year. It was just comparing the strength and hypertrophy effects of different glute-based exercises like bridges and deadlifts and single leg Romanian deadlifts versus lunges and squats and step-ups and stuff. And it turns out that there really isn't any major difference between those movements as long as you're loading them really heavy. In fact, you can get a ton of solid glute growth by going very deep in your lunges and your squats. And that's generally my preference if I can. Also just because they're more functional, right? Like you're going to have a lot more carryover to life than doing a bridge unless you're doing jujitsu all the time.
Right. Yeah, exactly. I think that's a really good point to bring up. And, I think you mentioned as well with doing, squats and whatnot, pistol squats, just some more things I like to add on to that too is, I really like doing things like Peterson squats, or like low bar back squats, the lunges like you mentioned. And of course, every now and then if I have someone who's deconditioned and, I'm not going to put a barbell on their back if they're at risk for falling. And so, yeah, we'll work on some what's called open chain exercises where that foot isn't on a stable surface. It's not planted, right? So that foot's moving in space. So things like sideline hip abduction or, things like standing hip abduction or hip extension, just doing the motion can be really beneficial for an individual that doesn't have that strength to do a complex movement. But yeah, like you said though, Peterson squats, pistol squats. Another one I'd like to add is, like suitcase carries. So putting a heavy weight on one side, unilaterally, so only putting it on one side, and then just walking 40, 50, 100 feet with that, making those or overemphasizing those hip abductors to do more work. So next question for you, Christian. All right. So I had a friend tell me about his PT, and he didn't really remember what the PT said, but he was talking about how the difference of like if your pain is in the front of the hip versus the side of the hip. And I got completely lost with what he was saying. So my question for you then, Christian, is why about these different locations, like front, side? Why does that stuff matter?
Yeah, so pain on different sides of your hips generally means different things. So what if you have pain in the front of your hip?
Mm-hmm.
Common diagnoses you'll hear about in this area are, one of them is arthritis, which you can have pain all over with arthritis, but generally you'll see it a lot in the front of the hip. And they'll also have a lot of pain and stiffness in that area that's not very specific to a singular spot. Other diagnoses include hip impingement or labral tears, and then also tendinopathies of those hip flexors or those adductors, which are your groin muscles. And the way that you treat most of these diagnoses is by finding comfortable exercises that challenge the hip in a lot of different directions. Like you mentioned, those different planes of movement. And then scaling those exercises up into harder versions over time until the client can do all the different things that they want to do. And I find for this area that working up to the patient's pain threshold, but not often exceeding it, works pretty well. The only exception to that would be tendinopathies, where it's totally fine to work into some pain, and in fact, it could be more beneficial if you do. Now, what if you have pain in the buttock area? Diagnoses there often include piriformis syndrome. And this one happens a lot with people that sit a ton for work or they do a lot of driving. And it's characterized by pain in your butt and numbness, tingling, or burning down the back of your leg, which is called sciatica. Piriformis syndrome is more or less a way of your body telling you to get off of that sciatic nerve more so that it can breathe. When nerves are constantly compressed, they can have issues. You can also have low back issues refer pain into your buttocks. And this happens a lot with disc herniations as well as stenosis problems. When the nerves really close to your spine, called your spinal nerves, get angry from inflammation being in the area to heal an injured disc, for example, or they are truly compressed from some stenosis, they often send pain into the buttocks and down your leg. And this is another reason for sciatica type symptoms. Then a couple other ones that you can have are high hamstring tendinopathy, which is usually in that lower butt cheek area, as well as gluteal tendinopathy. And then lastly, what if you have pain on the side of your hip? Anytime someone has pain around that large bony bump on the side of your hip, we call that greater trochanteric pain syndrome. Gluteal tendinopathy is a super common reason for greater trochanteric pain syndrome. And these diagnoses are very common in middle-aged folks as well as folks that are a bit older. They're not as common in younger athletes. You can also get some high IT band syndrome type pain here, which would feel more like a painful rubbing sensation on the outside of your hip at that greater trochanter.
I thought that was a really good way to just succinctly wrap all those different areas up. I think that can be a little confusing for individuals at times, is, you know, kind of what you just really explained with all that. And especially the idea of sciatica, or that presence of that nerve discomfort going down the back of the leg. The difference between, is it coming from the hip, or is it coming, or that piriformis area, or is it coming from the low back?
Yeah, I mean, you hear it every single day, at least every week in the clinic.
Yeah.
Like someone walks in, like, yeah, I got sciatica. I'm like, yeah, okay, well, we got to figure out where that's coming from, because that's just the name of a symptom. It's not a diagnosis.
Yeah. Yep. Whoa. Did you just say that sciatica is a symptom, not a diagnosis? Get out of here.
It's like vertigo, right?
Yeah, that's true. Yeah, man, we talked about this. We have to do a podcast on that sometime. Yeah, vertigo versus true vertigo or not, right? That's the discussion. Wouldn't have to get into that at some point. But anyway.
Well, yeah, we'll get back to some hip diagnoses, and I want to ask you about one in particular. So, Eric, my doctor said I have hip impingement. How can physical therapy help if it's my bones that are messed up?
Yeah, that's a really good question. So first I want to dissect this by talking about what that hip impingement is and what the kind of diagnosis is and why this happens. So this is can be common in individuals, especially very active individuals. It's called femoral acetabular impingement syndrome, or FAI. Now, if you want to think back to the beginning of the podcast when I broke down that hip joint and the two bones that kind of make it up, that ball in the socket, this is where that kind of it comes back into play here. So when we're looking at FAI or hip impingement, that's usually coming from two different spots. You mentioned, Christian, about how the bones being, maybe abnormal in some way, right? And so what that's referring to is these two different types of lesions. When we say lesions, we're just talking about this bone growth coming at some weird times in some weird areas. So it can be what's called a cam lesion, which the head of that femur that we talked about, the ball in the ball and socket, cam lesions can have some abnormal bone growth on that head of the femur that when you try and flex or move that hip, it's going to cause some irritation in that hip joint. Conversely, we could also have pincer lesions. Now, pincer lesions are on that acetabulum, the socket portion of the ball and socket. Some individuals can have one or the other. Some individuals can have both. Either way, individuals that are very active more commonly get these, and we feel the pain discomfort coming when we are flexing or forcefully moving that hip. So you mentioned, how can PT help this? So let's just set some realistic expectations. I'm not going to change your bony anatomy. You could argue if we did a crap ton of hip extensions and we got some stress to that femur from the glute pulling on it, you could argue that we're going to make that stronger and change the anatomy of it. But in this case, we're not going to really reduce the bone growth in that area. But there are several things that we can do. Number one is education. Education is huge in this, is what we see in research. Education and activity modification. Both of those things can really help individuals out to just calm that area down. Now, even though we're not changing the bone, we're still calming down your symptoms of sensitivity or irritability. The third piece of that puzzle is doing a really good objective examination and subjective and finding out what impairment level things that you have going on that we want to work on. Now, that could be mobility, or that could be strength, or that could be endurance of some type. Whichever it is, we want to attack those things very specifically. So we're looking at impairment-based rehab. So if that's mobility, strength, conditioning, etc. We're looking at activity modification. So if you're a runner, maybe we just have to take a little bit of time off and do some cross-training of some sort. And then lastly, education on the diagnosis itself. Now, I just want to end with this because I thought it was really interesting. Back studying for the OCS study, when I was studying for it, they have an article in there that mentions a study from McGovern et al. And they did a research study of 8 weeks of a comprehensive rehab program of those things I just listed. And what they found out was through activity modification, impairment-based exercise, and education, individuals significantly improved on performance of step down and single leg squat tasks, and they showed a subjective or self-reported functional improvement. So what we see with this is that it can actually be pretty beneficial for individuals, even if we're not physically changing the anatomy.
Yeah, that was a great explanation. This one's tough. I get when people come into the clinic and they're like, I have this meniscus tear in my knee. How can you fix that as physical therapists? Or the hip impingement topic you're talking about now. The cool thing about these injuries is you don't need to fix them for you to feel better. I know we talk about this a lot in probably a different podcast. People have these issues all the time and don't even know it, like large proportions of the population. Mm-hmm. And you got to ask yourself, okay, how come they don't have pain yet they have these things just like I do? And how come I have pain? The whole point of these movements, these exercises, the activity modifications and all that you're talking about is, at least the way I like to explain it to my patients, is we're not really fixing that issue. We're just teaching your hip how to forget that it's there so you can go on about your day. And the fact that it's there isn't going to lead to some major lifelong problem. You're not going to make it dramatically worse by doing something. You're just good to go. We just got to get you back on track.
Last question of the day. So, Christian, I'm a runner. I love to run. Am I at a higher risk for hip injuries if I want to go run every day?
Definitely. You are at a higher risk of injury in the hip as a runner. But That's mainly just because you're running. It's not
Mm,
that like running is inherently injurious. It's just like if you start doing anything, you're probably going to have some issues along the way.
mm-hmm.
But specific to runners, hip injuries are actually quite common. I just read a study that combined the results of a bunch of other studies, and they said that the hip is where 5 to 40% of running related injuries occur. For context, the knee was where 7 to 50% occur. The most common hip injuries that I see in the clinic are, unfortunately, definitely stress fractures. A lot of people don't know that they're doing too much too fast, and it just leads to these stress fractures. Another common one is gluteal tendinopathy. And then one that doesn't really have a name that I would call just generalized pain. These folks don't have a clear reason that I can nail down at least as causing their pain. They
Mm,
seem to hurt at a constant amount during a run, but maybe it'll get better, maybe it won't. Sometimes it gets worse, but that pattern is inconsistent. We should watch these folks though for stress fractures because those are notorious for being a little bit weird. But they're usually characterized by like a deep aching pain that just keeps getting worse the more that you do. The generalized pain people often do really well with a running deload or a programming change, like starting to run on different surfaces or changing the shoes that you run in, having a shoe rotation. Or
mm.
instead of doing all steady state running, you start throwing in some intervals. And of course, adding in a healthy bit of resistance training, especially training areas that are weaker when comparing that strength side to side, or you do see some glaring coordination issues. And then maybe you add some stretching if something is obviously tight and could be limiting their ability to get into efficient positions, or just stretch if it feels good. It's not bad, and honestly, it might help. Now, I mentioned earlier how weak hips are linked to pain in the entire leg, but it's not just weakness though, it's those coordination issues I talked about. And specific to running, you can trace injuries like IT band syndrome or patellofemoral pain syndrome, which is also called runner's knee, and shin and foot stress fractures to issues with how you control your body when you strike and when you put weight through your stance leg. Now, what do I mean about how you control your body? I mean that the hips play a large role in where your knees go and where your feet land. And certain shapes that we make at the knee and in our feet are linked to pain and injuries. Having strong and coordinated hips helps your whole leg land well, land strong, helps you decelerate, and then allows you to propel forward. Not only does this decrease your injury risk, it also makes you far more efficient or economical at running, so you recycle impact force better to help you spring forward. So in short, strengthening makes you a better runner.
Absolutely. I like how you threw in a plug for resistance training because you know that every endurance athlete loves getting under heavy weight. I really like that explanation and discussing, the different aspects of, possibilities around running, and it can just be as simple as making some type of modification to either the training or something that you're running on or running with. All that stuff can make a difference, even if it doesn't seem like it's a big deal. Sometimes it's the easier things to fix that can make a big difference. So I really like that. Awesome job.
Yeah, thanks. I liked all your answers to the questions too.
All right. Look at that. We're gonna have to start finding topics here that we disagree on.
I'm sure
So
we
we
will over
can,
time. That'll be fun.
yeah, we can start talking and then I don't know, hopefully keep a good friendship after. But no, I really liked all that stuff you had to say, though, Chris. I thought it was all really good information. And again, hopefully individuals, they're going through something that's related to one of these things, if it's hip impingement, running injuries at the hip, or even lower in the chain, or you're just interested to know more about what the hip actually is. Took some good knowledge away from the podcast here today. So thanks everyone for listening, and let us know if you have anything we can help you out with, if it's programming or injury related or just other ideas on more podcasts. So I think that's all we got for today. Thank you, and we will see you all next time. Have a good one.